So hyponatremia isn't one of those diagnoses where the patient checks in saying, I'm feeling a little hyponatremic today. It is usually somewhat of an incidental finding. Like they come to the hospital for something very different, and in the process of working up their other symptoms, we discover, surprise, their sodium is off too. And the symptoms of low sodium range from completely asymptomatic to seizures, coma, and death. So there's a lot to unpack with this one.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
To really understand hyponatremia, let me start by sharing a patient story. So I get called to rapid response for altered mental status. The patient's confused and only oriented to person. She's lethargic, but also able to follow commands, and she has no focal neurodeficits. Her last known normal was yesterday-ish. The nurse said that the nurse prior to her said this is kind of how the patient's been. But now the family's at the bedside and they're stating that she is not like this at all. And then when they saw her yesterday, she was normal. So let's back it up a bit. We were able to get a more detailed history from the family and from reading her H&P in the chart. For the sake of this episode, let's call our patient Mrs. Saltman. Mrs. Saltman checked into the ER 2 days ago for increasing lethargy and shortness of breath. Though 89, she lives on her own, she tends to her garden, and is always hosting big family gatherings. Per her family, Mrs. Saltman is very sharp and quite independent. She even drove herself to the ER. So she does have a history of heart failure, which she takes all the standard treatments for, ACE inhibitors, diuretics, beta blockers, etc. This admission, she has some pulmonary edema. Her BNP upon admission is greater than 2,000, and her initial sodium was 126. She was admitted for further diagnostics and treatment of her congestive heart failure. So now, 2 days later, after some diuresis, now she has altered mental status, even though all of her vital signs are stable. So we get some labs, and we're seeing some worsened renal failure, and her sodium is now 116. Again, all her vital signs are stable, but since she's symptomatic and quite hyponatremic, we decided to transfer her to the ICU, where they could more closely watch her sodium and be really precise with her sodium replacement. So if you're thinking, what's the big deal with low sodium? Like, don't we want heart failure patients to be on a low sodium diet anyways? And why was her sodium dropping so fast in the first place? Then stay tuned so we can talk it all through. Let's start by understanding what hyponatremia is. Hyponatremia occurs when there's an abnormally low level of sodium in the blood. Sodium, an essential electrolyte, plays a crucial role in maintaining fluid balance within the body. So when sodium levels drop too low, it disrupts the delicate balance of fluids inside and outside of the cell. Remember osmosis from chemistry? So fluid will follow wherever the higher concentration of solutes is. So low sodium in the bloodstream, aka hyponatremia, means fluids will shift from the intravascular space into the cell. This imbalance in the concentration of sodium in the blood leads to water moving into the cells, causing them to swell. This is particularly concerning with brain swelling or cerebral edema, which can result in symptoms like headaches, confusion, seizures, and in severe cases, coma and death. Okay, I got it. Or so I thought. I thought I pretty much understood hyponatremia until I started prepping for this episode. Ha! Y'all, there is so much to learn regarding hyponatremia and how to manage it, and my level of knowledge is so far from that of a nephrologist, but I have learned a thing or two, which I hope to share with you. It's just probably going to take a couple episodes to get through it all. Okay, so what are some of the causes of hyponatremia that nurses should be aware of? Hyponatremia can stem from various factors, from not enough salt intake, to too much water intake, to too much salt being diuresed out, to diarrhea, vomiting, and of course, conditions that confuse the kidneys when they inappropriately concentrate the urine. So normal sodium level is 135 to 145 milliequivalents per liter. So anything less than 135 would be hyponatremia. But the level at which we start to worry kind of depends on how acute or chronic this hyponatremia is. So generally speaking, here are the levels of severity. Mild hyponatremia is 125 to 135. Moderate is 120 to 124. And then severe would be less than 120. That being said, one patient with a sodium of 120 might be walking around completely asymptomatic, as this is just part of their chronic disease progression, while another might be very symptomatic and needs emergent interventions. One of the concepts that I've learned in my research on this episode is how hyponatremia is categorized based on the tonicity of the blood, as well as the patient's volume status. This actually helped me conceptualize the causes and hence the treatments a little bit easier. So if you remember, tonicity and osmolarity are a reflection of the amount of solutes dissolved within the blood. Gosh, I remember sitting in chemistry class in high school and thinking, I am never going to use this stuff. And here I am, 25 years later, applying that knowledge to how I care for patients today. Okay, so there are 3 categories that a hyponatremic patient could fall into: hypertonic hyponatremia, hypotonic hyponatremia, and isotonic hyponatremia. Let's break them down. It's about to get real sciencey. So before I lose some of you guys on your drive to work, let me just summarize the most important points. You can come back to all this sciencey stuff when you're ready. All right. First, hyponatremia can range from not a big deal to, oh my God, irreversibly life-threatening real quick. Altered mental status is going to be your first concerning symptom, followed by coma or seizure. So know your patient's baseline so you can know when there's been a change. Next, it's also important to slowly replace sodium. Going too fast can lead to cerebral edema and something terrible called osmotic demyelination syndrome, which usually causes irreversible neurological damage. And it's also important to not just treat the sodium, but to treat the underlying cause that led to the hyponatremia. Okay, so now let's talk about the types of hyponatremia as categorized by serum tonicity and the patient's fluid volume status. So to understand hyponatremia, we first must understand blood tonicity, also known as serum osmolality. With serum osmolality, we are measuring how much solute is concentrated in the blood. So not just sodium, but other solutes like glucose. If you've ever had to give D50 or 8.4% sodium bicarbonate, aka a bicarb amp, you know how hypertonic those solutions are. They have a high concentration of solute in them, making them very difficult to push them into the IV. Like I have to use all of my strength to push an amp of D50 and a good amount of my strength to push sodium bicarb. Okay, so back to the serum. Normal or isotonic serum would have a plasma osmolality between about 275 to 290-ish. Hypertonic is greater than 295, so a higher concentration of solutes, and hypotonic would be less than 275, give or take a few, depending on what guideline you are using. So when looking at sodium, we not only have to look at the sodium level, but also the tonicity of the blood. And this will give you a starting point to determine the cause and appropriate treatment. So let's start with isotonic hyponatremia, or like normal level of tonicity with hyponatremia. So the amount of solute dissolved in the blood is the normal concentration. But with hyponatremia, we would expect a low tonicity since we're low on the solute of sodium. So this tells us that there's some other solute that is highly concentrated in the blood other than sodium. So that could be, an elevated glucose like in DKA or HHS, or there's other medications that can cause the tonicity to increase like mannitol, or patients who are post-procedures like a TURP where they use sorbitol or glycine for surgical irrigation. These, however, are not considered to be, quote, true hyponatremia because the amount of other solutes is just shifting fluid around to make the sodium seem lower than it really is. But the fact that the tonicity is isotonic, well, this is a much safer state to be in than a true hyponatremia because the concentration of solutes in the blood is not actually low. Okay, there's also hypertonic hyponatremia. So the blood is hypertonic, meaning there is a higher than normal concentration of solutes in the blood. But it's not sodium. When it's hypertonic, this is usually from high triglycerides or high proteins in the blood. Again, we aren't expecting a true hyponatremia to present with normal or elevated serum osmolality. But the true hyponatremia will have a hypotonic osmolality to match it. This is when the sodium is less than 135 and the serum osmolality is less than 275.
Hey guys, I'll get back to the show in just 1 second, but before I do, I have a request. If you have ever gotten any value from this podcast and you want the show to continue to grow, to access more awesome experts in the field, and to keep providing you with more nursing knowledge and inspiration, could you take a minute to leave a rating and a review? Those reviews on Apple and Spotify go a long way in getting this podcast in the hands of more nurses and bringing new guests to the show. And they just make my day to know that my stories and nerdy patho breakdown are helping other nurses thrive, or at least survive. So if you're feeling up to it, I'd love to see a rating and review from you. Thank you so much. Now back to the show.
So once we have determined that we have a true hyponatremia, then we have to look into the volume status. Patients can develop hyponatremia from low volume states, like if they become severely dehydrated or have been given a ton of diuretics and they've peed out all of their preload and salt, or they've had fluid losses from vomiting or diarrhea, even insensible fluid losses like from sweating or burns. There's a reason why sports drinks have electrolytes, namely salt, in them, because when you're losing water, you also lose sodium. Hyponatremia can also develop in euvolemic states. This is where the amount of intravascular blood volume might be just fine, but the concentration of water to solutes is off. So we see this in multiple patient populations who chronically have poor solute intake. So the elderly who eat what's referred to as the tea and toast diet, where they're not really taking much nutrition in, or alcoholics who just drink beer all day as their source of calories, but beer is quite lacking in solutes. And of course, patients with anorexia who aren't really taking anything in at all. We can also see this in patients who just drank way too much water. This used to be referred to as psychogenic polydipsia because it was something related to psychiatric conditions which influenced patients' decision to drink an excessive amount of water. But now it's called primary polydipsia because we also see this in like fraternity hazing rituals or people who are water loading prior to drug screens. And I'm sure there's lots of other reasons people might drink an unadvisable amount of water, but you can see euvolemic hyponatremia in this patient population. Additionally, adrenal insufficiency and hypothyroidism. There is one last condition that occurs in euvolemic patients that causes hyponatremia, and that is SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. Literally anything can cause SIADH, like anything, from medications to cancers, brain injury, respiratory failure, even pain can throw someone into SIADH. This diagnosis is so fascinating and it deserves its own episode. But for now, just know that it might be the source of your patient's hyponatremia. And finally, we can see what I personally see more than anything else is hyponatremia in patients who are hypervolemic. So this is your fluid overloaded patients like liver failure, renal failure, and congestive heart failure that leads to hyponatremia. And this was the case with Mrs. Saltman. She was having a CHF exacerbation, which happens often for patients with heart failure. Despite diuretics and all of the appropriate pharmacological interventions, her heart just could not keep up with her fluid volume, and fluid started to back up in her lungs, leading to pleural effusions. With heart failure, you have a low cardiac output. So even though there is more than enough volume in circulation, the heart is just not pumping it around effectively. The body senses this low output state and tells the pituitary to release anti-diuretic hormone. So then the kidneys hold on to more water and further dilute the blood. So it is kind of common for patients with later stage heart failure to have hyponatremia. I could do a whole entire episode on liver failure and how it leads to hyponatremia, among other things, as well as end-stage renal failure. But the important takeaway is the solution is not a liter of normal saline for these folks. They're already fluid overloaded, so replacing sodium has to be done with a little more concentrated doses because isotonic normal saline could just lead to more ADH release and further exacerbate their condition. So we've talked about differentiating true hyponatremia with hypotonic osmolality to match it, and also other types of hyponatremia that have isotonic or hypertonic osmolality. Okay, we discussed hyponatremia in patients who are dry or hypovolemic, those who are euvolemic, and those like Mrs. Saltman who are hypervolemic or volume overloaded. It's important to know which one you're dealing with so you can know how to treat the source. Let's talk about treatment. It seems easy, right? Just give them some salt. I was telling my husband about my episode and how challenging the content was to convey because of the multiple causes of low sodium and how risky the treatment can be. And he, not being in healthcare, was like, how complicated can it be? I mean, give him some salty food. Great idea. To which I responded, no, you don't understand. Low sodium is so complicated that most doctors don't even want to treat it alone. When the sodium gets too low, they consult a specialist, the nephrologist, to weigh in on the treatment. Low sodium is super dangerous, and replacing sodium too quickly is even more dangerous. So let's talk through some of our treatment options. We'll start with simple. Free water restriction. Dude, when I worked in the CVICU, it seemed like every patient was on a free water restriction. These poor guys would be so thirsty, and I'd be like, I'm sorry you're thirsty. How about some milk? Restricting water intake will eventually change the sodium to water concentration and return the patient to an isotonic state. Then there are sodium tablets. These are debatable. They work in theory, but then they make the patient more thirsty. So if they're thirsty and they go chugging water, well, we've kind of defeated the purpose. Then there is saline or 0.9% sodium solution. This is a nice, gentle way to replace sodium, but not every patient can handle that much volume, nor will it help every hyponatremic patient, depending on the reason for their low sodium. Next, there is hypertonic saline. So really concentrated sodium solutions. These come in multiple concentrations from 3% saline to 23.4% hypertonic saline. Yes, I said that correctly, 23.4%. These can be given as a bolus, like 100 or 150 mLs of the 3% saline over an allotted amount of time. And that allotment depends on how symptomatic your patient is. You can also hang 3% hypertonic saline as an infusion and titrate to achieve the sodium correction level that you're shooting for. I have only ever given 23.4% hypertonic saline to patients who are at risk for herniation, and we are trying to rapidly reduce their intracranial pressure. Another option for when you're needing to correct sodium quickly, say like the patient's actively seizing, and you don't have time to wait for the pharmacy to mix up a patient-specific batch of hypertonic saline, is to just grab an amp or two of sodium bicarbonate off the crash cart. Sodium bicarbonate has a sodium tonicity of about 6% sodium chloride, but you still need to give it fairly slowly, like over 5 minutes. The big risk of treating sodium is overcorrecting, and this is actually pretty easy to do. If you start replacing the sodium and you treat the source of the problem, we reverse that, now the sodium is going to start to climb even faster than what is safe. So too rapid correction of sodium can result in something called osmotic demyelination syndrome, which usually results in permanent neurological damage or death. So, the recommended rate at which to shift the sodium varies greatly depending on which article you read and how acute the initial shift was. But if the sodium starts rising faster than the team deems as a safe amount, they might want to start D5W or DDAVP. DDAVP or desmopressin blocks water excretion, which allows us to control that factor, which might contribute to overcorrection. I've heard it called the DDAVP clamp. So you put the clamp on and take a tighter control of the factors that might affect the trajectory of the sodium shift. Then, as the sodium corrects safely and slowly, you let off the clamp. So this episode is not about when to use which treatment. That is why nephrology is often consulted on these hyponatremia patients, because it's just complicated and risky. But I wanted you as the nurse to understand the rationales behind each intervention. Like, why are we restricting someone's fluid intake? We're trying to balance their sodium to fluid ratio. Why are we giving someone saline versus hypertonic saline? Why is it important to go slow with it? That's the stuff I wanted to cover today. So let's wrap it up. Let me see. I think I mentioned doing a future episode on SIADH as well as liver failure, because there's so much fun pathophys for those two diagnoses, and they deserve their own episode. But to summarize what we discussed today, symptoms of hyponatremia can vary greatly depending on the severity and rate of onset of the hyponatremia. Early signs may include nausea, vomiting, headache, muscle cramps, and as the clinical condition progresses, patients might have confusion, lethargy, weakness, and even seizures, coma, and death. It's essential for nurses to recognize these symptoms promptly and bring it to the rest of the medical team to get interventions going. Treatment may involve fluid restriction, intravenous sodium replacement, and most importantly, addressing the underlying condition which caused the hyponatremia. Know that the treatment can be just as risky for seizures, coma, and death as the hyponatremia itself. So be cautious and closely monitor the patient's labs and clinical presentation. For those of you who stuck with me until the end of this pathophys heavy episode, thank you. You should give yourself a pat on the back just for making it through. You are my hyponatremia warriors. I hope that this episode will help you understand the why behind all the complexity when it comes to recognizing and treating hyponatremia.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.